I think there's the little sign that says you are live. We're actually having a little difficulty getting our guest on today. We're now doing this on something called StreamYard, which is really cool because as you guys have been seeing, I've been able to have, that split screen. I could even have two guests on. But first of all, we have to get the guest on. Hi, Jeanette Persons from sunny Lisbon, North Dakota. Just finished walking 30 blocks. Beautiful outside. And it's beautiful here too. I mean, we really haven't had sunny weather here in Southern Connecticut, but it's supposed to be like almost 80 today. And let me say hi to a few more people. Donna Lynn, hi, Joan from South Jersey. I assume you've got, it's very hot there today. I want it to stay this way. I want summer to be here. Hey, Beth, you're in Naperville, Illinois. I wonder what it's like there. And Vincent, hey, Vincent. Tell us if you're comfortable walking around New York City, because you're in New York City, I think. And if people are starting to go out, I don't know. I don't think businesses are open though yet. Maybe you can tell us. Mari, is that it? Marye. Savard, hi, and Olivia Crockett. Laura Hargis, happy Friday. It is Friday. Oh, Anime Foley, you're in Fitchburg. Thunderstorms? I'm trying to figure out where you are in relation to me. And Marion O'Brien Lowry, happy Friday. It is Friday, isn't it? And Olivia Wells Crockett, and you're from Alabama. Is it warm down there or stormy? Maybe warm, humid, stormy. I don't know. And Gayla Welton, yay, we are here. It's been crazy busy week at work. You make my lunch break enjoyable. And Pam, is it Boquin? Hi to you and to Eileen Cates and to Sharon Robinson. So listen, and Pam, you're in Buffalo, right? It's in like the 70s. You had snow last week, right? We had like an instant. It didn't last very long, but it was snow. I mean, I looked outside and I said, it didn't snow. And my daughter said, yeah, look at the top of the lounges. There was like white snow on them. So it is Friday. My big news today is it's move day for my office. I moved out of my, I had kind of this big office and we had a lot of people working in it. And I got to tell you, this is what the pandemic is going to do. It's going to make a lot of people rethink how they do their work. And I decided I don't need that office, which cost me a fortune to run. So I gave my notice and I'm moving in. My husband has a building like 2 doors down, and he's been telling me forever, I don't use the bottom floor, move in. So that's what's going on. I went there at 8:45 this morning, did manual labor, came home all sweaty, jumped in the shower and showered and blew my hair dry so I could be here with you guys. And so I'm here on kind of the lunch break, and then I'm going to go back over and do some more manual labor. By the way, this is like a big old sweater, those kind of cool sweaters, but I don't want you to think I'm really that big. It's better when you see it in the whole frame, if you know what I mean. You guys, do you know what Friday, May 15th is? Are you ready for this? You're going to like this. It is National Chocolate Chip Cookie Day. Can't you just smell them? If you have the goods in your house, I mean, you want to be patriotic. And this was on the official list of nationally observed holidays. So I think you might have to slide some chocolate chip cookies into that oven. But we're not done. It's National Pizza Party Day. That's right, National Pizza Day. We haven't had pizza for quite a long time. That sounds like kind of a good idea, actually. Something's wrong with this picture, though. National Chocolate Chip Cookie and Pizza Day, and the last day of National Women's Health Week. So this has been going on all week, and we've had, we talked with the oncologist that, designed my treatment plan We had her on Monday, Ruth Oratz. And, we talked with yesterday. I know you guys enjoyed yesterday, Dr. Diane LaRusso, the radiologist, talking about mammograms and the importance of them. And if you've had your mammogram appointment canceled, just keep calling. Some of you said that your doctors wouldn't schedule an appointment until the end of June, but make them schedule one for you, because the bottom line is you do not want to let it go by. Okay. So I was just thinking about National Women's Health Week. Chapter 9 in my book, which I assume that most of you by this time you've gotten. And of course, what's the motto here in our little group? Tell your 10 best friends about it. Come on, I need you guys to commit. So chapter 9 is become the CEO of your health. And I'm just going to start out as my introduction today to Dr. Garber. Your body is just that, yours. You're the only one listening to it and monitoring it daily. The only way you can protect it is to take responsibility for it. So how do you do this? Imagine, go with me on this, okay? Imagine if we treated our bodies with the same respect we treat our cars. I happen to love this analogy, so stick with me. If you're driving down the road and that little orange idiot light comes on, reminding you that service is required, boy, you take your car in to find out what's wrong with it right away, right? Because you want your car to keep running in good condition for as long as possible. Well then, why don't we use that same level of care with our bodies? How many of us have had aches and pains? That's the equivalent of those little orange idiot lights that we've ignored because, they'll fix themselves. How many of us are on schedule with our annual physicals? Who among us has visited their dermatologist for an annual skin check? And by the way, I asked you if you wanted to have Dr. Neil Schultz back, and he is back. He's going to be with us, I think, on Thursday, talking about the fact that May is National Skin Cancer Awareness. And I asked you guys yesterday if any of you had never had a head-to-toe skin check, and some of you admitted it. You told me you hadn't. So we're going to be talking to you guys next week. Who has seen their gynecologist recently? Ask those questions at your next girls' lunch. And I bet most of you will have your tail between your legs. So why don't we make these appointments? Too busy? Need to find a new doctor? Maybe you don't want to hear any bad news or be told that you have to drop a bad habit, or worse, that you need to lose 10 or 15 pounds. Oh, no, thanks. I'm good. Maybe I'll just wait till next year. Well, that, ladies, is the wrong choice. Ladies and gentlemen, I don't forget you, Vincent. And I am here to be that annoying friend who prods you to change your ways, to make and keep all of those appointments. Yes, I am, because I don't want you to break down in the middle of life's freeway during rush hour. So today, I have somebody as a guest today that I so admire, that is so terrific, because, we've been talking to all these different doctors. We've been talking to radiologists and oncologists and dermatologists, but all the doctors in the world can't help a patient, that doesn't hear somebody like me saying you need to go to the doctor, but also if we don't have researchers and scientists all around the world researching and finding good treatments for us. So today our guest is Dr. Judy Garber, and looks like we have her. She's an oncologist. She is the chief of cancer genetics and prevention at Dana-Farber Cancer Institute in Boston. And she is also the chief scientific director of BCRF, Breast Cancer Research Foundation. And they have an advisory board to help identify all the scientists and researchers around the world and which ones should be funded. This year alone, Breast Cancer Research Foundation will give $66 million to researchers and scientists around the world. I think there's about 126 scientists in over 40 countries. And I got to tell you, this is going to be great news for all of the women that I hear from all the time battling metastatic breast cancer. This year, a large amount, I think about $33 million, almost half of it, is going to go to researchers who are looking for new treatments for metastatic breast cancer so that we can turn this into a manageable chronic illness instead of a death sentence. So I want to introduce you to Dr. Judy Garber. Hi.
How are you? Hi, Joan. How are you?
So good. I think the last time I saw you was in Boston.
I think so.
We were at a big BCRF luncheon, a pink luncheon, and you and I were both on stage that day. I'm excited.
It's not a good act to follow.
Yeah. I'm excited to talk about all of the scientists who are coming up with the treatments, because doctors can only help a woman battle cancer, or a man. We have to remember men can get breast cancer too.
True.
And there are many other kinds of cancers. If we have the scientists coming up with the treatments. So we know one thing that you've taught me and other oncologists have taught me is that breast cancer is not one disease. And until I was diagnosed with breast cancer, I don't think I really understood that everyone's breast cancer essentially is different. So we have to treat it, each one of those in a like way that will really go toward that one. So what have some of the more recent breakthroughs been that have really been exciting?
So let's just clarify this issue of breast cancer as not one disease. And that's probably true for cancers in general, that we think of cancer as a huge word, but it's many, many different subtypes. In breast cancer, I think anyone who's had it has had to learn that we divide it into tumors that are driven by hormones, like most of them are, and those that have figured out how to grow regardless of whether there are hormones there or not. And then tumors that are driven by a molecule called HER2, and those that are not. And some tumors are neither hormone driven nor HER2 driven. We call those triple negative. And you know that whenever you do that, it's because you don't really know what's driving them.
And everybody kind of knows that I got diagnosed with triple negative.
Right. So that's been the hardest to characterize. So people have tried, the most common are the estrogen receptor positive, HER2 negative breast cancers. And those people have understood in some ways for the longest time that hormones were the drivers, and that if you got rid of the hormones, not that you like how you feel, but that it does sort of starve the tumor or block growth of the tumor. And many women have taken drugs like tamoxifen or aromatase inhibitors to try to change their hormone environment and make it so that these tumors can't grow. The metastatic problem is when they figure out how to grow despite that. We'll talk about that a little more. Some of these other tumors respond either to drugs that target HER2 or to drugs that were just sort of our old chemotherapy drugs, but now we have something different. So for the estrogen-driven tumors, the biggest change has been drugs that target a molecule called CDK4/6. These drugs are drugs some of you may recognize: palbociclib, ribociclib, abemaciclib. I only know the generic names. But these have totally revolutionized the treatment of hormone-driven disease. They make hormonal therapies more potent, and they treat the vast majority of disease. So they have become part of the mainstay of the first treatment for metastatic disease. Not that tumors can't figure out how to outsmart them, but they make a big difference from the beginning. They've expanded survival. For tumors that are HER2 positive, we started the world with a drug called Herceptin or trastuzumab, which is an antibody. So it doesn't have all the usual chemotherapy side effects. But now there are a whole group of new drugs that target other parts of the same molecule. And it turns out that you can give a lot of them in combination. So it doesn't make it cheaper, but it does make it more effective to target these things using multiple agents all at the same time. And that these drugs in breast cancer, people have always known that if they work in metastatic disease, you try to move them up earlier to prevent the metastatic disease. That is what we'd like to do. but these drugs are all active in metastatic disease, and they have made a big difference there as well. And then even for triple negative disease, that has where other immunotherapies are beginning to show activity. And we all would love to have immune therapies that are effective and that don't have the same side effects as chemotherapy, although we still have to learn how to make sure that they don't have their own side effects to manage.
But I've talked to a few people who went through immunotherapy and said it was really tough.
So immune therapies, you know, I would say like chemotherapy. We started out with chemotherapy. We had to learn how to manage the side effects, or we would not really benefit patients. We would make them miserable, but not necessarily cure them. The same is really true with the immune system. So we've always wondered, why doesn't your body see that tumor as a foreign invader and get rid of it all by itself? It's a perfectly good immune system. But it turns out that cancers are sneaky, and they started in your normal cells. So your immune system just says, a little different, not different enough, lets it go. Now you have to turn the immune system on, and you have to make it more aggressively attack those tumor cells. And the problem is, like chemo, we're not so specific in the beginning. So we're learning how to do it more effectively and safely, but it's going to take a while till we have that all figured out. And that means that there definitely are side effects. So this is not benign. It's just different.
Is the immunotherapy being used for certain kinds of cancers? Is it an effective way to deal now with breast cancer? Or I'm not sure where they.
So immunotherapy had their resurgence in melanoma, a very disease to treat that had a big immune component, and kidney cancer, another place where chemo didn't do much, but the immune system did. And now bladder cancer, lung cancer, whoever expected this? Breast cancer has been a tougher nut to crack. Why that's true, I don't think we know. Triple negative has had the most benefit to date, but people are certainly trying to figure out how to manipulate the immune system to target estrogen receptor positive breast cancer and HER2 positive breast cancer. If you're using antibodies to target HER2, that is immune therapy. You just have to figure out some of the rest of the balance. So we're not done.
Absolutely not. Right now, as you kind of look, because you're the chairman of this group that looks at every researcher around the world. And usually we have a big gala here in New York City where we literally have almost every one of them, all 126 researchers and scientists all up on the stage at a hotel in New York. And it's just mind-boggling to look at this body of incredible brilliance and experience. Of course, we can't do that this year, but you're still, looking at all these scientists and deciding who to give the funding to. What are some of the avenues of research that you think will hold the most promise?
Well, so I think immune therapies are here to stay, and to make them work, people are studying which immune drugs, which targets, how to make them safer, and how to predict which will be most effective when. So there's a huge amount of immunology that you need to know to be able to manipulate these things. So it's its own group. The other piece of immune therapy I think we should not give up on in any way are vaccines. So we're all waiting for the COVID vaccine to protect us from an obvious viral infection. But I think we should be also holding out for vaccines to prevent breast cancer from starting.
Oh my God.
And also vaccines to help change therapy. So vaccines are also a very promising immune area.
But is that on our horizon? Like, is that in the foreseeable future that we're going to have a vaccine for breast cancer?
Well, let's say this. So I'm not that young, but I'm not planning to retire till we have one. So I would say they better hurry up. But yes, there is activity in this area, in colon cancer and in other cancers. So we should all hope for vaccines, I think, and then we can debate their pros and cons. What else? How about earlier diagnosis of metastatic disease? Okay. So we all live with mammograms and MRIs and ultrasounds and imaging that we know for early detection is a challenge. But we want to find metastatic disease when it's the earliest possible time. So there's the least possible disease. That should be when you have the best chance to try for a cure again. So there are lots of studies that I'm sure you know about, Joan, but maybe everybody else doesn't, looking for what they call minimal residual disease or minimal disease circulating either tumor cells or perhaps more likely DNA that comes from the tumor that you might be able to find even before you can find an abnormality on a scan. If that, I mean, so it has to be that you find it and that you can target it and try again to kill the tumor. But there is hope that if you could find these things early enough, that you really could eliminate those cells that are becoming resistant to the original treatment or have figured out how to grow anyway. So they call these liquid biopsies, so-called biopsies, looking at the blood, not for tissue to biopsy, not for scans to find the lesion first. I think that's a very promising area because the technology has come along that lets you find tiny amounts of DNA. Think about pregnancy tests now. Things are so different. People are pregnant, they have a blood test to see if the baby has Down syndrome or another chromosomal defect. Finding molecular abnormalities in the mother's blood from the tiny bit that's the baby. That's basically what you want to do for metastatic disease. So that's another area where I think people are very excited that there might be high yield, high risk.
I know that there are people that are, there are scientists looking for a blood test.
Yep.
You know, that you would be able to take and find something to tell you early on. Is that a viable thing that?
Well, you know, at the moment, I would say it's too early. There were two big presentations just a little while ago at the ACR meetings that suggest that we're making progress. But, you know, those are places where you've got to be right. So if you find that early marker and you can't find a lesion anywhere, how do you know for sure it's correct? And have you told somebody they might have cancer when they don't? So we have a lot of work to do to make these perfect. If they're ever perfect, but close enough. But yes, there's huge effort going on to try to make these possible as early detection tools better than imaging, or at least complements of imaging to make imaging better. Other ways to make imaging better, artificial intelligence.
Ooh, and that's
learning. Lots of people trying to see if computers really are that much smarter than radiologists. Can you find things?
If they can find breast cancer, if they can find breast cancer, I'm all for it. I looked at the numbers this morning. I looked at the numbers of how many women in America have metastatic breast cancer, and it's an incredible number, 276,480. But it said only 6% of those were diagnosed with metastatic breast cancer right from the start.
Well, that is because women have been, I mean, despite everybody's disappointment in and skepticism about things like mammograms, women have embraced them as an imperfect tool and find most breast cancers early. So fortunately, only a small group of women have advanced disease when they're diagnosed.
We have someone, Pat Little. She wants to ask Dr. Garber if, once again, if she heard you correctly, that immunotherapy is being used for triple negative breast cancer. We have a lot of people. It used to be that someone like me was an outlier.
Right.
Now we have more and more younger and you know, different, you know, it used to be primarily, if I'm correct, older and African American. And now we see younger and younger and people like me. So I don't think I'm an outlier anymore necessarily.
You're just younger. But aside from that part, no, it's true. So it's about 15% of all breast cancers, and it often is in younger women and in African American women, but it can be in anyone. And yes, Ms. Little, immune therapies are being used more in the treatment of triple negative breast cancer to try to make chemotherapy more effective. Unfortunately, not all triple negative breast cancers will respond. And there are some markers that your oncologist might use to try to figure out if the ones we have today are more or less likely to be effective. But that is progress. We didn't used to have this. And in the last few years, we've learned that there are places where this can make a difference.
Well, I know I was up at Dana-Farber doing interviews with, and I can't remember his name, one of your researchers there that's specifically studying triple negative breast cancer. And he said, I remember he told me, you know how there's like the 3 buckets of breast cancer, then there's this triple negative over here. but he said that they're really finding that there's different buckets even within triple negative. So as they start to break that down and understand triple negative better, I would assume that it will become easier to try to find some targeted therapy for those buckets.
I think that's really true for all breast cancers, that, one of the problems is that we can use these buckets when the tumors first appear. And then when metastatic disease comes along and when people go through different treatments, that the tumors are changing, or at least within the tumor, the population of cells that becomes the dominant population is changing. It's like antibiotics and bacteria. You treat and the bacteria gets resistant and figures out how not to be killed by the drug and grows the resistant cells. And that's what you see in breast cancers too. There are patterns. Triple negative tumors become resistant in their way, estrogen-driven tumors in their way, but there are different patterns. And yes, people are busy looking at every pattern they can find, trying to figure out where's the Achilles heel, where's the weak point, how do we get rid of this aggressive population, how do we get rid of that one, so that, as Joan said, if you're talking about this as a chronic condition, you don't really want to be going through different treatments all the time. But even if you have the option that when something begins to grow through, you can nip it in the bud, knock it out in the whack-a-mole approach to cancer, that's a possibility. Not good enough. Not eliminating metastatic disease. That's where we want to be. But at least on the way there, trying to figure out all the different things that we should be able to target to eliminate the bad guys when they act up.
Before we get to metastatic, we have several women. Dana Babonis, she said she tried to schedule her mammogram. She was supposed to have it in March. She was now told that they won't be taking appointments until June. Several other women, they're saying here, like, how worried should they be? And what advice are all of you giving to these women who can't get in to have their mammogram or their ultrasound?
Well, COVID has certainly caused problems in this regard. But I think the reassuring thing is that for most women, so let's say if someone is not really talking about screening is when you have no symptoms, asymptomatic, no problems, just want to go for a check. In that circumstance, a few months, probably really most of the time, does not make a difference. If you're someone who has anything that's made you worry, a lump, for sure, a discharge, pain, something that made you worry. Now we're not talking about screening anymore. Now we're talking about trying to diagnose something. And those that you should be able to get in. If you call the mammogram center and have a problem, they should try to get you in. But for screening, remember, in some countries, screening is recommended every 2 years, not every year. So if you have to put off your mammogram for a few months until they can offer it to you and until you feel safe going to that facility to have a mammogram in this COVID time where you'll be adequately protected, then I think it's okay that a few months can pass by. Is it important to get it yearly? I see it on the screen.
Yeah.
I think for most of us, yearly is the right thing, but I have to admit to this, but as you get older, even though breast cancer incidence rises, there are women who can go to every other year if they really don't have a lot of risk factors. And I think that's something that primary care physicians are trying to help them figure out. For the most part, we say once a year. So I would still stand by that, but there are times when that is when a longer interval is possible.
Here's Maria DeCasto. Hi, Joan. I'm a triple negative breast cancer survivor. I'm on my 5th year. And because those are, so the audience knows, those are fast growing cancers. And so if they don't grow back, you're pretty much, it's not like estrogen based cancer. I want for the doctor to tell us, when are you more or less out of the woods with triple negative breast cancer, since it's not a hormonal breast cancer? So you go ahead and give the official answer.
Right. The official answer, Joan, is of course, absolutely right. That for these tumors that are fast growing, if they don't come back in 3 to 5 years, they're very unlikely to come back. So you should celebrate. The problem is for the majority of women who have those estrogen-driven tumors, they're very sneaky. They just, some of them, for reasons we don't understand, they can be gone for 20 years and suddenly you find them again and you wonder, what have they been doing all this time? So it's harder to celebrate that 5-year survival. I shouldn't say that. it's always good to celebrate your survival. 5 years is good, but you can really feel more out of the woods if it was triple negative to start with.
I'm trying to read Veronica. Can you tell what TILs? TILs in
Veronica's been reading her immunotherapy. So here's the question: how do you know when immune therapies might be effective? And one of the things people have been looking at is, can you tell by looking at the tumor if they have cells that look like active immune cells already infiltrating the tumor? So the pathologist looks under the microscope. I know you've taught everybody about this, Joan. You can see those tumor cells, but what if you also see a lot of lymphocytes trying to infiltrate the tumor? TIL is tumor infiltrating lymphocyte. If you see a lot of cells, that suggests that the body really does know that there's something going on here. And maybe those are the tumors where if you could just ramp up the immune system a little more, you'd be more effective. And there's some data to suggest that that's true.
All right, so here's Cheryl Ann Cunningham. Is the success of the immunotherapy dependent on your age, i.e., does younger mean a better system and therefore maybe a better outcome due to a more robust, what she means is immune system?
Yeah, I think there are a lot of logical assumptions that you think would be predictive. I don't think that has been shown yet, but I would also say, remember that often in clinical trials, which is where a lot of immune therapy is still being done, younger women are more likely to participate. They're otherwise healthier. They may be able to take the risk if something could be tougher. So we're going to have more data on younger women to begin with. I think that's an interesting question. And as usual, the question would be, what's young? But so that I don't know. But I wouldn't give up yet being older.
But that's also an interesting question because you know that there have been entities, basically the Preventative Task Force, don't get me started, that, put out this recommendation that we wait till we're 50 and get them every other year. And then the American Cancer Society, I think, got their arm bent up behind their back and they kind of met them halfway and said, all right, just wait until you're 45. However, I've not talked to an oncologist or radiologist to date, and I talked to a lot of them, who have ever said that they agree with that. They all say start when you're 40 and maybe even a baseline at 35. I can tell you just anecdotally, I hear from women on Facebook all the time being diagnosed in their late 30s and early 40s. So if they followed that recommendation, that could be a death sentence.
Can you believe after all this time, we're still trying to figure out how to do this? My whole career, we've been thinking about this, and it's really a challenge. I think people have tried to use other, do you have a family history? But of course, most women don't have a family history.
I didn't have any family history.
It's not a good criteria, and they've tried other factors. Dense tissue on the mammogram, but you have to have a mammogram to know if you have it. And young women usually have dense tissue. So I think for most women, most oncologists, certainly most primary care physicians and gynecologists have tried to suggest that these things that mammograms should be done earlier. But, we're never, as Ms. Traylor is saying, we'll never find the 25-year-olds that way.
Yeah.
And sometimes those are people with inherited risk because those often can be younger, but they may not even realize it. If they've had a family with mostly men, you may not see the family history.
But you have to go up that side. But don't you go up that side too? Like if if the husband's grandmother or mother had breast cancers, a lot of time people forget they only look up the mother's side.
That is an important message, Joan, that family history matters on both sides. But it's still true that in some families, people only have sons, or the grandmother, it came from the grandfather and you just can't see it. So family history is tricky. We don't always know our family histories, and family histories can be misleading. But on average, let's say, okay, we don't want every 25-year-old to have a mammogram. Fortunately, it's still rare for someone 25 to have breast cancer. We better be thinking about other things for them. On average, should we be doing mammograms in women only when they're 50 and only every other year? And I think that's a tough pill to swallow.
Oh, yeah, me too. The people I hear from the most here in my Facebook world are women that are battling metastatic cancer. And there's always been this sense that, that we're out looking for all these other great treatments for, all the other three kind of cancers. But, those of us with metastatic, we're just going to die. And I want you to explain to them that that is not the case today.
Well, that is not the case. And that I can tell you with great confidence. Yes, of course, we want to cure women up front naturally, but we don't do that all the time either. So we know we have to do better. And really, the main difference to me between my life now as an oncologist and my life 20 years ago as an oncologist is that clinical trials have so much more promise. When I started, clinical trials were the last resorts, and maybe they worked because many of them were things that were derivatives of drugs that might have worked. But now you have immune therapy trials, you have combination trials, you have much more rationally designed drugs. And the only place to begin to try them is in metastatic disease. So there's a huge amount of work trying to make a difference in metastatic disease. Some of it in hopes of making treatment of early disease more effective and preventing metastatic disease. Okay. Yeah. But much of it for women themselves with metastatic disease. I am grateful whenever my patients have metastatic disease to have the option of many trials so that we can go from drug to drug looking for the ones that are going to make the most difference for them. Nobody wants to give up. And no one wants to say, oh, metastatic disease, it's too late. Nobody would do that. But it is true that we have not figured out how to cure metastatic disease the vast majority of the time. Well, you can never say never anymore because some of those immune patients actually have very long-term responses. Oncologists are careful with the word cure, but let's hope so. And if that's true, then we need to understand why so we can make sure more people are in that position.
I remember going to the NIH, going to the National Cancer Institute. I did a story there for the Today Show with Dr. Steven Rosenberg.
Oh, yeah.
And he had a patient that fought hard to get into his trials and never gave up, persevered. And her breast cancer had then spread to her lungs. And they were able to take, some of the tumors, and they then gave her chemotherapy and took the immune system down, and were able to go back in and make those targeted cells. I'm probably really summarizing in a very lay way, but to really go in and kill all of those tumors in her lungs. And she was almost like, a modern day, what was the woman?
Lazarus.
Yeah, she really was like a lab rat. But,
no, Lazarus, I said. I mean, she really was resurrected. She was like somebody who was facing death and her disease has disappeared.
But they not only had her disease disappear, but they made millions, gazillions more of those cells that became those targeted cells that I guess can be used in other patients.
Well, yeah, I think that's a big question too. What are the features that tumors share with each other that would give you a common form, some immune therapy that worked for a lot of people, or how different are these tumors? How unique do they become after all this treatment? That's where the targeted therapies have been challenged. And even if it takes combinations, we've talked before today about putting drugs together, even if you don't know exactly which it is, if you can put together a good panel of drugs, you may have a good effect. I think Steve Rosenberg's work has been amazing. Fortunately, he's not the only person doing amazing work in breast cancer. COVID's going to come, it's here, and it will go. Breast cancer will still be fighting.
Absolutely. I think about HIV. They were able to make HIV into a manageable chronic illness as opposed to a death sentence.
With cocktails of
with
drugs.
Cocktails. So is it kind of in the foreseeable future that we could make metastatic breast cancer into a manageable chronic illness?
I certainly hope so. I think we do it to some extent for the hormone-driven breast cancers, but that's a very relative definition. People live more years, but they live with disease. And living with disease is a very different burden from living without disease. So, so chronic disease, diabetes, hypertension, we manage those things, try to keep them from causing trouble. I'd be happy if we could do that for all breast cancers, but I want more. I would like to eliminate disease.
Well, this is not breast cancer, but Carol Shapiro is asking how often women need pap smears and at what age is it no longer needed? Or should you just keep getting them?
No, I think that, they've changed the guidelines over the years, and they've mostly made it dependent on whether you have HPV, papillomavirus. And,
right.
Hopefully our daughters' generations will all be immune, but otherwise people who have not had, who are not positive can stop. People who've had a series of normal pap smears, like 3 in a row that are completely normal, many of those women can stop. So pap smears, you don't have to continue forever. You may like your gynecologist, you may want to go for other parts of the exam, but pap smears no longer are an eternal commitment if you have been healthy. If you have any kind of issues, however, of course, pap smears should continue. They remain an important screening tool. They are, but they're not, but you don't have to do them forever, because cervix cancer is really an infectious disease. It's a viral condition, and that's why you can stop if you don't have the infection.
So,
and there's a vaccine that prevents cancer. So how do you like that?
HPV.
HPV.
Now, I got tested and I didn't have it.
Good.
However,
a lot of people do. It's very common.
Yeah. Well, I didn't have it, and then I had all my 3 girls tested, and they didn't, so they got the vaccine. Right. But he said they don't give vaccines to when we're my age and married. And
well, let's not discuss the epidemiology of sexually transmitted infections. But if you didn't have it, it may be because you're already immune. HPV viral infections are so common that for people who don't have them, they may have had effective immunity before. So you probably didn't need that vaccine now. Also, the time of getting these cancer means a lifetime of exposure to the virus, so it has time to transform to malignancy. But that's cervix cancer. Today is a breast cancer day.
Absolutely, and today is breast cancer. And this has been really fascinating. And for metastatic, for all the women who are really battling metastatic disease, to hear that there's as much funding going to find answers to that disease. Before we end, Marie Thomas, thanks, Joan, and thanks to Dr. Garber for sharing all of this. So interesting. I know you have patients, and I promised you that I would get you back to them.
Thank you.
And thank you so, so much, Dr. Garber. I've always just so admired you. And it was really such an honor and a pleasure to get you to join us today.
Thank you for having me, and thanks to your amazing audience. They have great questions. You must really be teaching them well, Joan.
I'm trying. All right. Bye-bye.
Bye.
And so next week, just remember that I have, just because National Women's Health Week ended, it's also National Skin Cancer Awareness. And this is one, because I asked a bunch of you yesterday if you had never had a head-to-toe skin check. And there were a bunch of you that said, I've never had one. They're so incredibly important. So we're going to have Dr. Neil Schultz back. We can also ask him shallow questions. We can ask him about Botox or anything else we want. But he's going to be here to really talk about skin cancer. It is the most preventable cancer of any of the cancers, but it's only preventable if we get the head to toe. And I'm also going to have Lynn Lyons back. Do you remember Lynn Lyons? And she was talking about anxiety and sleeplessness. Well, I'm going to have her on Thursday, next Thursday, and it will be exactly 8 weeks since she was first on talking about anxiety in the pandemic. I don't know if any of us really thought that we were still going to have her. She's going to come back and talk about where are we all at this point. And on Feel Good Friday, I'm going to have Jackie Falco, and she is a nutritionist. She's got great substitutes for snacks, and she's going to be here to hold our hands so we go into the Memorial Day weekend with our heads on straight. Okay. All right, everyone, have a great weekend. All right. It's Friday. Have a great weekend. See you next week.